Well, good afternoon, ladies and gentlemen. Welcome. It's great to see you all here. My name is Saravana, and I'm one of the panel members here. We usually have a chair for the session, but unfortunately, the chair couldn't make it. So basically, we are freestyling, as the young people would call it, and so the panel members are also going to act as chairs as well. So the aim of this session, right, is to give you guys an overview about the vast amount of options you have in healthcare, because other than medicine and nursing. Because often when you think about health, most often than not, we often think about medicine and nursing. But here we are going to tell you that that's not limited to medicine and nursing. There is a plethora, a number of other professions which are equally important and available to you guys as you're making decisions about what careers that you want to choose. So the way we're going to run this is I have a presentation which I'll just show you about my background. Bob will then have a few minutes to present his point of view from his professional point of view, and then Andrew will give his perspective from his professional point of view. Afterwards, let's try and keep it as interactive as possible. We'll ask some questions of each other, but please feel free to ask any questions that you might have, because the more questions you ask, the more answers that you're going to find as well. And as I say to my students that I teach, there are no bad questions, because I'm sure if you have a question, someone else is also thinking about the same question as well. So that's the aim of the next 45 minutes to an hour. Right. So my background, as I said to you, is I teach at UniSA, and my background is as a physio. So I'm just going to spend some time talking about what a physio does and what other options physios often have in healthcare. So I'm going to talk about physiotherapy in the 21st century. Now, what do you think physiotherapists do, right? So now, if you are queasy about any injuries, look away now, close your eyes, because I'm going to show you, because often what people think about when they think about what physio does is they think this is what we do, right? We treat broken bones. So you can see here the runner, that right lower leg doesn't look right, does it? It's pointing in the wrong direction. The rugby player's left knee is abnormally flexible. Again, that's not normal. And then you can see the basketballer's kneecap pointing in the wrong direction, right? So often people think that's what physios do as well. And then recently, I did warn you guys, right? I did tell you to look away. And so in this case, you can see this another basketballer whose foot should be pointing straight, but again, it's in a right angle to where it should be. So often when people think about what physios do, this is what they often see. Physios running onto the field, treating sports players, and that's what I thought I'd be doing. I thought I'll be working with Sachin Tendulkar, which if any of you cricket tragics would know, one of the greatest Indian players. We'd be stretching people's hamstrings, we'd be working with footballers and soccer players and so on. And yeah, that's true. Some of us do that. Some of us do work in the sporting areas. But guess what? There's more. We do a lot more other things than just working in sports, physiotherapists. Why? The reason we often work in a number of different areas is because healthcare in Australia is rapidly changing, and I think you will hear from Bob and Andrew as well about how this is changing in the last few years. One, Australians are getting older. I tell my students, right, you better study hard because one day I will be your patient, right? And in terms of getting older, we're not just getting older in terms of getting 40s and 50s, but research tells us by 2050, quarter of the Australian population will be more than 65 years of age. So it's a lot of us who will be hitting in their late 60s. Not only are they getting older, we are also having multiple chronic conditions. Chronic conditions basically means conditions which we cannot necessarily cure. Things like diabetes, heart disease, lung disease. We can never treat, never cure them, which means they're always there for the rest of our lives. Also, rarely do patients present to us with one problem. Many patients that we see often have complex issues like heart disease, which is also present with low back pain, which is also present with diabetes, which means managing these people becomes very challenging for us. Because our money is so tight, the government is also saying we can't keep investing more and more in the health system, we have to do things better. And so they are coming to us as health professionals and saying, what can you do to add value to the health system? Finally, right, one of the things that has also changed in the health system is when I graduated, and I tell students that this is when the Spice Girls were on top of the charts. Does anyone remember Spice Girls? Yes, that is going back 20 years. When the Spice Girls were on top of the charts when I graduated from physio, patients were merely seen as a passive recipient, which means, I am the holder of all knowledge. You will come to see me. I will treat you the best way I see fit. Don't ask me any questions. Whereas now we've shifted that model where patients are an active participant. So they actually make decisions with us about their health system. And finally, in terms of things like inequity, what we know as people from the country, and I'm sure some of you are from the country, people from the country tend to have poorer access to healthcare. So if you are someone who's looking to find work in health area, country areas tend to often have a lot more job opportunities than city, because in country areas there's not enough health professionals. So there's a number of things that has been changing in the Australian healthcare environment. So what do physios do? We do a lot of things. We work in a number of fields to keep Australians healthy and staying well, and that can be in a hospital setting, typically like the Royal Adelaide Hospital, Flinders Medical Centre, Queenless, Hampstead and so on. But we also work in community areas where we know we have communities of practice. Large number of physios work in private practice, whereby we see patients who walk from the street. We work closely with other health professionals in a collaborative multidisciplinary care. Often physios work hand in hand with a number of other disciplines because, as I said to you before, patients present to us with multiple conditions, which means physiotherapists by themselves can't manage all these conditions. You have to work in collaboration with others. Very importantly, we work across a continuum. We can see patients in the sporting field. I used to work with a netball club called Metrics, where for netballers who get injured in the field, we'll treat them in the acute area. We'll manage them once they in our private clinic, and then we also treat them in terms of chronic wise. So we can work across a spectrum, all the way from the day the injury occurs, all the way we get them back to their normal healthy living. And some of us also can work in other areas like teaching, research and management. So I guess the key message from this slide is, in physiotherapy land, you have a number of different options. You can choose to work seeing patients, you can work in a hospital, you can work in a community, you can have your own practice, you can work in rural areas, you can work in metro areas, and you can also do teaching, research and involved in management as well. So you can see there's a number of diverse options available to you. In addition to where you work, what we actually do as physio is actually very different as well. Many people often think physio means back pain or neck pain or shoulder pain. That's one area, and we call it musculoskeletal. But you may not know, physios often have a role to play in things like cardiorespiratory, like asthma, teaching people how to breathe properly so that they can get good lungs. We work in cancer, in terms of breast cancer, how physios can help with lymphedema, which happens as a result of breast cancer treatment. We work in women's health, in pregnancy, in terms of helping women with antenatal and postnatal classes. We have a huge role to play in neurology, like stroke, because stroke rehabilitation is huge. And in Australia, the prevalence, the number of strokes that happens every year is increasing. We work in orthopedics, like total knee and total hip replacements. I was going to put a total hip replacement on video, but I thought it's too much for you guys, because it literally does involve hammer and sickles and so on. Occupational therapy, we work with injured workers to bring them back into the workforce so that they can continue working. We work with children in terms of looking at things like autism and developmental disorders. Chronic pain, which is a huge issue in Australia at the present time, we play a lot of role in how to better manage chronic pain. As you saw, we work in sports area quite a bit, and we also use things like aquatic therapy, pool therapy to help people with things like osteoarthritis, osteoporosis and obesity and so on. So you can see not only where we work is very diverse, what we do is also very diverse as well. So why be a physio? Well, it's a very rewarding career, and I can tell you, Andrew and Bob will tell you, we all came into this because we wanted to help people. That's the ultimate reason why you want to be a health professional, helping people and contributing to their well-being and quality of life. We think it's an exciting field to work in, and that's why we are continuing to work in this place. For example, the new I can never get my direction wrong. Which side is that? Oh, it's on this side. The new Royal Adelaide Hospital is one of the state-of-the-art hospitals, and to be able to work in such environment, I think it's very, very exciting. There's huge changes in NDIS and My Aged Care, where patients can work with us to help their conditions get better. Adelaide physiotherapists are recognized worldwide. Many of my colleagues often travel after they graduate, and anywhere in the world you go, physiotherapists from Adelaide instantly will be recognized and you will have a job opportunity. And you get to work in a diverse area, and as I said to you, a number of different settings and in a number of different fields as well. So I guess to summarize, be a physio. All right, look, I'll stop talking. and then I'll pass you on to Bob, who will have a chat to you guys about his perspective of why, what health options are available for you. Bob? Thank you.
Thank you. I'll take a slightly different perspective, and I'll talk about a journey that that I've had. Obviously, being a bit grey, I've been around for a while. I've been working in health settings for all of my career, which originally started as some time ago as a physical educator. But in those days, there was the trend to appoint physical educators into rehabilitation teams within hospitals, and so I started work on graduation at the Queen Elizabeth Hospital as a physical educator, and worked in then a rehab unit that they had established on the Old Port Road at Royal Park. And so, I've sort of followed that sort of pattern, but at a particular point in that part of my career journey, I developed more interest in physiology beyond the, let's say, the scope that a physical educator would normally approach health issues with. So my physiological interest was increased quite dramatically by the connection that I made with some physiologists at the Flinders University. So I went down the pathway of a postgraduate degree and eventually completed that. So my current sort of qualification is in exercise physiology, but in those years of study, I was more interested in developing more knowledge about stroke and post-stroke outcomes for the journey that people actually take in life after having a stroke. And it is a positive thing, it doesn't have to be negative. So that was what I did. So eventually I found myself at the Hampstead Rehab Centre, which I've worked at for nearly 30 years. During that time, the title exercise physiologist has actually increased quite dramatically across the community, but within clinical settings it's been recognised since about 2006 that exercise physiologists have a clinical role to play within the health settings that people find themselves in. And part of that is in acute hospitals, but that's a very minor role. In rehabilitation, which is a fairly major role, but also in the community in different settings, which is probably the major direction that people take when they complete their studies in exercise physiology, which usually begins now with a human movement studies degree. So, I'm sort of a little bit different to the current graduates, but my role at the moment is to manage exercise physiology within the Central Adelaide Local Health Network, which includes the new RA and the Hampstead Centre, where the primary group of staff that I am responsible for work, but also in what we call rehab in the home, which covers the new RA and the Queen Elizabeth Hospital, where people are let's say, discharged early with support from all sorts of people, nurses, physios, OTs, where necessary, speech, pathologists and nutrition, dietetics, and nursing. So, there are exercise physiologists in the system, and there are an increasing number of them. So how do you become an exercise physiologist in a clinical sense? And I've sort of outlined here on this excerpt from the ESSA. ESSA is the Exercise and Sports Science Australia group, and that's my professional body, and exercise physiologists are accredited through our professional body. And we actually have what we call a scope of practice, and this really outlines the detail of what we can do or should be expected to do under usual circumstances. But sometimes working in hospitals, people work outside the scope of practice because they have support from other health professionals to actually do things which aren't normally within the narrow confines of a scope of practice. So I'm not going to read that out, and I'm not going to tell you, because you can see there, you've all read it, I'm sure, what exercise physiologists do. So just moving on. What sort of things do we do more specifically? Well, we're interested in measurement for a start, because we want to really know what the status of a person is that we've never met before. So part of that is some set tests, I'll call them, and those assessment tests are undertaken to get a better understanding about what a person can do. Now, it's true to say, I think, that almost all of the health professions do some form of assessment at the start. You know, if it's psychology, there's going to be some sort of discussion which might be built around some assessment, let's say questions or whatever. Certainly in physio, it's all very similar. It's a pattern of protocol. So we assess people, and we use those measurements in order to then work out, in discussion with the person, what's important for them. Because, you know, it's okay for me to say, like the physio things, we do things for people, but in fact, in health professions nowadays, the better way of describing it is we actually work with people to do things which they need to do in order to become, let's say, have more control over their lives and their health, and that's the way that we approach it. So I've put up some graphs there. You can see there's one which looks at the lifelong journey, the one at the top at the left, which really just shows that, you know, over the lifetime people, you know, mature and get better at doing a lot of things in a functional sense. But at some point, people decline, and if they get to a particular point of declining, and this could be a fit and healthy basketballer who's had his left leg twisted at 90 degrees, and it's you know, major damage of the joint and all sorts of structures connected with it. You know, we know that function declines, and we can actually improve it through an intervention. So we're interventionalists. Now, we don't work in the health system alone, we work with others. So the idea of working in a multidisciplinary team, but also with other supports as well. There are a range of other people who work in sort of, let's say, usual health settings. You know, it could be a clinical nurse, it could be an allied health assistant, and there are lots of those people. Certainly there are an increasing numbers of people who come in with, say, TAFE qualifications, who actually perform essential roles in and across the health services, in private as well as in the public systems, in order to get better outcomes for people. So I'm not just talking about the professions, there are the other support service workforce as well, and they're essential because when we look at efficiencies, working together with those people to develop programs for people may give, say, one exercise physiologist with an allied health assistant, they may be able to deal with 12 people, whereas most times an exercise physiologist may just be working on their own with one person. So efficiencies improve. So that's what we work on in terms of the evolving system. How do you get into these careers? Well, if you want to be an exercise physiologist, and I'll be really specific about it, there are entry requirements. There are a number of pathways. It's not only through you know, secondary school graduation, but if you did come in that pathway last year, you would have needed an ATAR score of 95 to do the particular, or get into the pathway at Uni SA, and those particular requirements unfold a little bit differently for people who come in from other pathways into the tertiary system. I've put up a quote from somebody who's going, Erin Coots, who's going through the course currently, and you can see that, you know, as a school sort of in secondary, that person, Erin, enjoyed biology and physical education, and she chose the degree because that was what she felt would provide her with, you know, a work journey, workplace and a profession. And if you get into the profession and you work in SA Health, I've put this up for information. When somebody gets to about the 4th year of their career, starting off at the base grade level, which we call Allied Health Professional Level 1, AHP 1, and there are different levels within that. So there's each year people get an incremental increase in salary, but when they get to a particular point, usually around 4 or 5 years, if it's under normal pathway circumstances, they progress to AHP 2 and start on level 1, and the payment, the salary is up there for you to see. So it's not an insignificant salary. So AHP 2 is $77,752 to $90,029 salary, plus the other benefits that you get. And you know, one of the benefits which people get in working in SA Health is that they actually get, as an allied health professional, they get really good support to continue their professional education. And each year there's a sum of money which you can apply for in order to take up different education opportunities which may exist for you, which fit in with the system and your career journey in the system, but also for your own private benefit as well. So I'll leave my talk at that, because you can ask me questions a bit later, and I hope that's helped people. But you know, I've been specific about exercise physiology in a clinical setting, but there are other exercise physiology roles as well, and some of them are actually preparing those sports people in order to perform better and actually not have those particular injuries which physio deals with later. And physio and EP work together.
We do.
All right. So my esteemed colleagues here have got a presentation, but I'm absolutely freestyling it at the moment. So so it's a little bit of background. I think just to set the context to this is that I'm a pharmacist. I've been a registered pharmacist for about 12 years now. But I think, you know, as a very quick snapshot in Australia of pharmacy practice and think about what pharmacists do, there's about 28,000 pharmacists in Australia. But I'm imagining in the audience, you would commonly think of a pharmacy that you would walk into, drop your script off, the local community pharmacy. There's about 5,000 of them in Australia. But pharmacy is a very diverse profession. And I think looking at the audience as a quick snapshot, I think there's this view of pharmacy, I think as a whole, that you've got to go through a uni, which you do, you've got to have a degree, a pharmacy degree, you come out, you've got to be registered, and you go one set path. But looking at the audience, in my mind, I think people underestimate what supports need to be in for pharmacists. How do you keep a pharmacy operating? That's probably one thing to say. Second thing is, I think an understanding of what pharmacists actually do and what areas they can work in. So one of the, as I said, community pharmacy, I was talking to the gentleman next to me earlier, and I said, well, yes, I'm in community pharmacy. I'm a general manager, chief pharmacist, and I oversee a community pharmacy that's co-located in a private hospital that's co-located with a general practice. There is literally only 2 other of those pharmacies in Australia. They don't exist to have one that's located in a private hospital. But on top of that, you've got pharmacists that work in general practices. Then you've got those that work in manufacturing. So we have a manufacturing pharmacy as well. So we prepare injectable medicines for administering chemotherapy into our private hospital, and we supply, for example, some of the other public hospitals in South Australia. So there's the manufacturing side. Then I guess when you start to look outside of that, you think about clinical trials pharmacists, you think about pharmacists that work in Defence Force, looking at logistics, so when going to Afghanistan, a lot of those pharmacists involved in those processes. Looking at those that work in residential aged care. So I guess pharmacy practice as a whole is a very diverse area, and I think from my point of view, what I do every day, and just to give you a quick snapshot, my role started as a hospital pharmacist. I had a dream of being a clinical pharmacist working at the RA, which I did. I started off there. I went to the QEH and worked in clinical trials. I rotated around to manufacturing, clinical trials. I worked on the wards. I think from where I found my passion coming out was in manufacturing, and thought, you know, how can I improve pharmacy practice in manufacturing of drugs? And I saw a gap in what patient care was looking like, and I thought, I want to make a change. So when I went down that path, the next thing that really hit us was I guess, from where our business has gone of late, is that we're developing a medical device. So we're actually, we're downstairs, we have an exhibition down there at the moment because we're developing an infusion pump for global sales. And one of the things that I've had to do as a pharmacist is I've had to understand how medical devices work, how to engineer them, and how to put my knowledge that I had as a pharmacist, not as an engineer, I have to work with the engineers, but I've had to work out how to do marketing. I've had to work out, I fly internationally trying to work out how to get penetration and understand reimbursement in the United States, for example, versus Australia, and looking at going to the Chinese market. It's my role in the last 10 odd years has gone from being a pharmacist that thought pharmacy was only a community pharmacy, you drop your script off and that's it, to going, I wanted to be a hospital pharmacist, to going, now I touch many aspects of pharmacy practice. From, we have clinical trials, we do manufacturing, as I said, hospital, we actually do work in residential aged care as well, we supply into that. So it's a very diverse area of practice, and I think that's one aspect, but it's also about who you work with as a pharmacist. Most of our workforce at work is actually not pharmacists. I've got 17 staff and only about 6 of them are pharmacists, but I can't do it without the technicians, I can't do it without financial managers, I can't do it without our IT team, but they've got to actually understand how pharmacy practice is different to other areas of practice. And I think that's where, when you look at health, you can get so many professions that you interact with that people underestimate and think, oh, there's only one path. You go as a pharmacist and that's it. Or you come and work in a pharmacy, but it's so far from the truth. So many opportunities coming. And I think if I was looking in the audience thinking, it's more about where the future of the profession is going, I see it, and saying, well, what can we actually, what jobs are actually going to be there? Because I guarantee you the movement in community pharmacy is robotics. And I can tell you now, when I started, it was at the earliest stage, it was how quickly I could put a label on a box. That was literally my metric. But now it's about my cognitive service. It's about my value that I can add as a pharmacist, and if I can say it, let the robots put the label on the bottle, but then how can we help patients? So it's a dramatic shift that's happening at the moment. And probably only one thing to add we've touched on is my passion as a pharmacist. I guess really focused on home care, I guess, and the movement of getting patients out of hospital. So I've been doing everything possible with our business, and the committees I sit on nationally is how do I help patients move out of the hospital setting to be treated in the community. So we've built a business around it. I've built, I guess, my skill set around that, and looking at where I can influence the profession to help patients be treated in the home. So I guess that's kind of where my area of practice is anyway. So I don't know if you guys, any questions?
Before the audience asks any questions, Andrew, in terms of pharmacy, there's move towards using assistants and so on. And I know a lot of people would be interested in the assistant workforce. Do you guys use any assistant
Absolutely,
workforce?
yeah.
What role do they play?
And I think that's one of my passions, is that traditionally you would use a pharmacist in roles that are probably much more suited to other skilled technicians coming in, because some of the roles are, I guess you're trying to look at where the best value person you can get in. It's not about one's better than the other or one's more intelligent than the other. It's going, who can I get the best person to come in? And it's also someone that's actually got an understanding of that area. So we use a large proportion of assistants and technicians, but I really like to leverage off them because they're so knowledgeable. It's crazy. They're so underutilised.
Good. All right. I'll open. You guys can ask us questions. Anything you want? We can talk about the bachelor if you really want.
Yeah.
Hi, I just wanted to know how you would assist a patient to get care in their home, or how would you assist them to get to their home quicker as a pharmacist?
Well, one of the things that I always revert back to is one thing that pharmacy does very well. My starting point is supply, and I think there's a misunderstanding of how complex that is around. For example, we were talking about this earlier. If someone's actually in hospital, people underestimate that actually it's the state government funding that. And pharmacy outside of the hospital is funded by the Commonwealth. So what we do is we go, well, how can we work with the state government from a funding point of view? That's where I usually start and say, because a lot of patients we have will come out, and particularly palliative care patients, they come out and there's an assumption that the hospitals discharge them and that the patient can get supply. That's where our starting point is. So if I can get that right to actually make sure that the patient's not out of pocket and there's not a reason for them to go back to hospital. The other thing is around the services. So I'm also, one of the other things I'm an accredited pharmacist, so I'm accredited to do home medicine reviews as well. So one of the things I get is funded from the Commonwealth to actually go into someone's home and review their medicines and make recommendations to the prescriber, so it might be the specialist or the GP, and any change that we need to do those medicines, and also things that are going to support that patient in the home. The other, probably most critical part for us is that the strength of the business that I'm in and my expertise is around injectable medicines. So things like chemotherapy, antibiotics, pain medicines that are actually injected into the body through infusion pumps and things. One of the things that I'm big on is actually getting pharmacists involved in educating those patients to start with. Obviously that supply aspect, but also then looking at the reimbursement of things that are not traditionally pharmacy related, so consumables. So how do you, if you're going to give an injectable drug to someone in palliative care, so pain medicines, if you're going to deliver that, you need a pump, you need lines, you need nursing, you need someone to go out there and actually do the dressing changes. We need someone to actually, I think there's underestimation of the supply aspect where we developed our own. So one of the things I did is I dabbled in a bit of programming and I developed our own IT system at work to communicate with the patients to say, oh, your next delivery of your pump is coming out, the drug's coming out, oh, your script's running out, we'll coordinate that so there's a complete continuity of care. So that's where pharmacy, from my point of view, I see the real value. And it's about helping coordinate with specialty practices, whether it's general practice and then obviously some of the other allied health as well, and nursing, obviously. So I see pharmacy as very much a coordination role, and that's where I get my other staff members to really come in. We were talking about technicians and assistants. I really leverage off them because they have, dare I say, much better customer service than I've got, and they are brilliant at being able to coordinate and problem solve and then know when to elevate to the pharmacist, say, look, we need actually a pharmacist to actually communicate with that patient and solve their problems. So that's kind of a flying aspect of it, yeah.
Thank you very much.
One of the things that when we were asked to participate in this panel today, one of the reasons we thought it was really interesting to be here is because research tells us that there are two huge growth areas in the future, right? Two huge growth areas for jobs. The first growth area is disability. So there are, with NDIS coming on board, which is billions of dollars worth, the government is predicting we need to have a big workforce to be able to cater for it. And I'm sure you would have heard about how India is sometimes lagging behind. One of the reasons is that there is very little workforce to address that demand. So that's one big growth area. The other big growth area is aged care. Okay, as I said to you in my presentation, we know people are getting older and the diseases are more complex to manage, and the government is telling us that keeping people in hospitals for longer is actually worse for them in terms of health-wise. The sooner you get someone out of the hospital, the better it is for them. And Bob touched on functional decline, and people decline in hospitals. So we want to get them out into the community where people like Andrew can actually have a role to play in keeping them at home. However, to be able to keep older people in the community, you need to have a workforce that is able to match that. And that's another huge growth area. So in terms of you guys looking at where do I pitch myself in the future, I think the timing is perfect now because we are seeing these two emerging markets in disability and aged care. And I think that's where the workforce, health workforce, is going to be, not in the acute sector, not in hospitals per se, but in the community in terms of aged care and disability. Yeah,
I'd support that. And in fact, recently I was in a discussion which looked at where is usual rehab going, and if we look at some of the models from overseas and pick out some individual countries, in the Netherlands, for example, 90% of people are discharged out of hospital directly to home, whereas a higher proportion of people certainly in Australia and other places like England have tended to be discharged to a centre of some sort, and they've had inpatient rehabilitation. So there is a very strong review of, is that plausible? Are the circumstances of people going to dictate that it's possible to do that, or do they need more support? And of course, the evolution of our health system is looking at larger numbers of people who are older, who have hospitalisations, which hopefully won't end up in a change of where they usually live. So that means, for example, you're older, you become unwell for some reason, and you don't go back home again. You end up going into a care setting. So in order to get people back home, you need supports at home when they're discharged. So the whole system of supporting people to remain independent is changing. It's too expensive to just allow people to fall ill or just to end up in acute hospital and stay there for a longer period of time. That won't work.
Yes, sir.
Yeah.
So is there a question back there? Yeah.
Yes, sorry. I've got a question for Bob, two-part question. I think the first part may have just been possibly answered within the discussion you just had then, which was, with exercise physiology, is there specialisation around elderly, treating elderly, or the older people, I suppose? So maybe I'll just give you, whether you've got any more thoughts on that.
Ask that one first.
Ask that one first, yeah.
That'll be good for me. Okay. Exercise physiology is a relatively new clinical profession. So as a member of the Allied Health Group, 2006 was sort of like the tipping point. So that was when the recognition was given across at the federal level. In our case, the team that I manage at the Hampstead Centre had been growing for some time. And what we tended to do was, in our own unique setting, people were becoming specialists in particular areas. So we've evolved in a particular way. So we have actually two people who are very high level with cancer and exercise, so survival after cancer, even special programs delivered during treatment, as well as the longer term rehab that might be needed after. So there's the cancer group, there's the heart failure and cardiovascular group, there's the metabolic group, which includes diabetes and obesity. Then we've got the musculoskeletal group. So we have actually got a team of people who can more or less do all the same things, but they've tended to go down a specialisation pathway. And this is very similar to what happens to some extent in physio. So across Australia, there is more of in exercise physiology, there is tending to be a little bit more specialisation in exercise physiology at a clinical level, and that appears to be the pathway, which is quite interesting because 25 years ago when we set up the initial association, we actually had 4 specialisations, which people then opted to be one of those specialists. We dispensed with that about 15 years ago, and now we're going back to that same specialisation.
Okay, yeah, and I suppose just second part of the question was, what's your view around exercise? I mean, you talked about one of the key goals is the optimum health. Well, health is more than just a physical aspect. So what role do you think exercise physiology has in things such as treating clinical conditions with mental health? Do you have a view on that?
There is evidence that particular types of programs deliver good results for people in a mental health sense. But if we keep that as the body of evidence that supports it, and there's certainly been some very good studies conducted in Australia as well, so that evidence body is growing. Not every exercise physiologist has the skills or capacity to actually work in the high end of the mental health sector, but every exercise physiologist has a set of potential benefits which they can deliver to every person. And we know that if people, in a general sense, are fitter and their physical health is better, there's a stronger correlation between that and better overall mental health. In our setting, what we are finding though is where more of our referrals are coming in with mental health as an additional key referral criteria. And so we're being forced to grow into that area and understand it better. And so we're, let's say, developing our education strategies there. I'm not exactly sure of what's going on at the every university level, but there are certainly within the course guidelines for exercise physiology, which are used for every course across Australia, there are elements which consider mental health as in a general sense, and then some, depending on the staff in that unit, they may have better capacity to educate their students.
If I could just add to that, I think it's important. I guess it's important to understand that there's two things probably. I think when I think about pharmacy, that we're looking at wanting to be more specialised in certain areas, and mental health's one of them. And what we're, I guess it's all postgraduate though, so it's not necessarily part of the graduate course, but it's more about looking at when you're actually in the profession. When you go into an area, especially most people, such as myself when I started, I just got dumped into clinical trials or manufacturing and said, sink or swim. Whereas now what we're going, let's try and formalise those processes and make sure that people are actually competent in those areas. And also, how do we interface with other healthcare professionals? And that's one thing that was probably been missed for such a long time, I think, in pharmacy. So there's this definite trend towards specialisation, but also there's a big push from the Commonwealth in particular. We're talking, I hope there's no prescribers around at the moment, but there's a big push to expand the scope of practice of all healthcare professionals, because I think the Commonwealth has felt for a long time the colleges of each of the medical specialties have limited the expansion of other areas, because that's where the money comes from. It's locked into the specialties. So I know that they've come to the pharmacy profession and said, okay, show us what you can do and expand your scope, and show us that you can do some of the things that they can do. And I know that's happening in other healthcare professionals. So when I see the future being bright of, I think, pharmacy or other allied health, I think it is about that we need to understand better the areas that we're working in and really do it well, because there's a big push to get those professions out there. And as you say, mental health is one of them. Aged care, definitely, that's a massive one at the moment.
Just adding on one very quickly, in terms of education-wise, 10-15 years ago, we used to see health as very biomedical, meaning that you had a biological problem. Like, if you came to me with a sore shoulder joint, then the problem was your shoulder joint. Now the shifting has completely changed, where we now look at a person in terms of more biopsychosocial, which basically saying that when a patient presents to us, there is the biological, there is a psychological, and there is also the social part, all feeding into how a person experiences their disease. And so across the board, you will see whether it's physio, pharmacy, exercise physiology, the issue of recognizing the biology with the psychology and the sociology is embedded nowadays as part of teaching and learning.
Given what you've just said and the complexity of that, how is it managed independently across organisations for lay people that don't understand? I mean, they've found themselves ill, they've been discharged from hospital, there's a whole process. Who manages this, or where does that management come from?
There is no one singular profession which you can say here is one profession who manages it. In the past, in hospital setting, we used to have something like a discharge planner, where just before what used to happen is that when you were admitted in hospital, you were meant to have someone who would coordinate your discharge planning. So the role of this particular planner was to basically ensure that you had all the support networks in place, so that when the time came for you to be discharged home, you were able to discharge home safely and effectively and quickly as well, because you don't want to keep people in hospitals for very long. Now, the role of discharge planners comes in and out of favor, pretty much like many things in healthcare. So nowadays, there is no one set person who often runs it, but often happens at a professional level. So whereby all the professions work together and to say, when can we ensure that the person goes home from hospital into the community. One of the challenges that we face in healthcare is how fragmented the health system is. That's huge, and I'll be long gone from this face of the earth, and I'm sure we'll still be talking about the same issue because of funding. Because state government controls part of the funding, Commonwealth government controls part of the funding. So the transition from hospital into community, that linkage is not as good. And also, even once you're in the community, how people link with other health disciplines often tends to be quite challenging. Just to give you an example, I'm married to an Italian, and she has a 94-year-old nonna. And only recently she went to nursing home from hospital, and she barely speaks any English, and so she would have all these people visit her who from OTs, physios, podiatrists, and every time we used to go see her, she'd have this new equipment. She had no idea who these people were, so these random people were all turning up, giving her frames, giving her this, giving her that. She had no idea who these people were. So that it is a challenge in terms of coordinating and making sure that the right services get to the right person. Yeah.
And I must say, I think that's the opportunity, and that's what excites me about with pharmacy when I think about, we also do research ourselves as well. That's one of the, it's traditionally done through academia, for example, but everyday practice I'm out there and I go, I wish I knew the answer to this because I could change practice. And one of the things that recently has come up is the hospital admissions from residential aged care. So most people think of hip fractures as number one. Well, it is number one. It's about 29% of admissions, but 27% of them are because of infections. And people underestimate, and that's where I think as a pharmacist, people go, oh, well, because it's a hip fracture, where do we fit? But when it starts to come to things like the use of antimicrobials and how do we coordinate that care, all of a sudden I see as a pharmacist the opportunity for us to come in, and that's where we've been working with residential aged care facilities like Helping Hand is one of them in particular, Rest Haven. They've got a big focus on hospital avoidance. So I guess that when you're talking about the coordination, there's no one single health profession that can even deliver the care if they tried, or even to understand it. It's so complex. And that's why you need each of the professions working really well together, and they aren't necessarily done directly at the healthcare professional either, because there's a lot of coordinators that are in there, and the jobs are insane. Like, it is just ridiculous, the number of people, and I think there's not one pathway just to come in and say, I need a undergraduate degree and that's it. It's just immense, I think, is an important point. Yeah.
In our unit, on average, we have currently about 350 new referrals a year, which is down about half of what it used to be 10 years ago. But the people that we see now are much, much more complex, and the discussions that we need to have with those people quite often start with even just some basic education about, the detail which they arrive with, which they don't understand. So, you have to pick out what they know and what they don't know and start from that point, because ultimately what we want to do is to actually have a set of discussions which centre around that person and allow them to make choices about what it is that we can help with in order for them to achieve what they want. And sometimes people don't want, and I've got a really funny analogy or little anecdote. We did some training with some exercise physiologists about 10 years ago to actually develop these skills of discussion with people. And the first thing we did was we wanted to know, why are people coming in to see you? So, when somebody comes in, some medical people will say, well, what are you here for? Of course, quite often GPs will say that. What can I do for you today?
What do you do?
Yeah, what can I do for you today? Or what are you here for?
Yeah.
In this particular case, somebody had been referred to one of our exercise physiologists, a very new graduate, and the person came in and they were very confused, and he said, well, I went to my doctor, all I wanted was for them to fix my teeth, and here I am with you. So where do you think that conversation went? So you know what I mean? So sometimes we end up with a set of circumstances which are very difficult to tease out and actually turn around. Why did that doctor make a referral to us? And there was good reason for it. It was a chronic disease-related issue. But you know what I mean? The patient didn't walk out of the surgery, the appointment with the doctor, with an understanding of that. So, clarification and discussion and good communication is where this will work or won't work. So we don't do things for people anymore. We do things with people, and we get them to do things and control it.
So we had a question.
Hi, I'm Kate Kimedia. I'm from Southern Cross Care, a big aged care organisation. Traditionally, allied health in aged care has been quite focused on a deficit model and looking at what people can't do. And we're, as an organisation, really trying to flip that around, and healthy ageing is our mantra. We're trying to employ lots more allied health therapists, physios, exercise physiologists as well. And I'm just wondering if the panel could comment from a provider perspective on how we can, better market our positions and opportunities to those enthusiastic new graduates coming through, to try and say, you know, aged care's here, it's a great place to work, to get more and more people interested in us as a sector.
Bob, you're up, Bob.
You know, people that come into these professions that actually get through the study and the evolution of their own level of understanding, what I've found is that they all tend to have a set of generic qualities, and one of them is it's either a level of sensitivity about others or certainly a sense of their purpose as a professional is to help people. And I think the hook for people who might be interested in these particular professions is to actually explain that better. So, you know, what it is, what the work setting delivers, not just for the person, you know, the focus of the service, but rather what it also delivers for the professional as well. So, you know, and there's some really, you know, fundamental, and it's not just about the buzz of feeling good about it, it's also a sense of achievement, you know, that, you know, somebody who wasn't walking and is now able to stand up and maybe take a step, you know, which is fundamental across a lot of the allied health professions in particular, and nursing. You know, those senses of achievement are the things which really need to be highlighted. Achievement as a health professional.
If I can add something there, I think I went through this experience myself with my 21-year-old daughter who's doing nursing now, and when she was in year 12 or even 10, 11, 12, we were going through this process, and she desperately wanted to be a paediatrician, desperately wanted to be a medico. And I said, you know, I hope she's not in the audience, she'll kill me. But I said to her, look, you're going to spend the next 12 years of your life doing ABC to be a paediatrician. And her personality was much more suited to nursing. She even talked about doing pharmacy. I said, don't even think about it. She was so suited to it, it was a perfect match for her. So what we did, one of our strategies going through this which is what I did as well, I went and did as much work experience as I could, and I put her through everything possible to give her as much exposure to all of the areas that she was interested in, and that, I guess that came across from, you know, from her point of view was, I always told her that the first job you get is never going to be the last. And I said, just give it a go. And one of the interesting things, she works at the moment, she's still studying nursing, but she's an assistant nurse at Lyell McEwen Hospital. So she does mental health ED, so she works in the ED doing that. And when she went into, she had to go to Oakden, interestingly. Sorry to bring up the politics here, but she did. And she went there, and when she got exposed to that and what was happening before that all fell apart there, she said to me, you know, how passionate she was for end of life as well, and she realised that she had a couple of patients that died when she was working. And I remember thinking when she came home, I thought, oh, this is a bit depressing, but she said, no, but I want to make someone's life, end of life, fantastic. I want to, rather than being right at the start from paediatrics, she totally shifted. And I thought, you know, just that exposure to those things and pushing her to be looking at varied areas of healthcare totally changed her view on it. And I'm very proud that she did do that, because it could have easily just gone, you know what, I'm just going to do standard out of the box, going to be a medico, I want to do this, and got her to think outside the square, and not about money, not about prestige, not just thinking, I want a future job that you're happy in, and, you know, that's what you should be working for. So, I mean, that's what, I mean, I do a lot, because I also do some tutoring and things like that with UniSA for the pharmacy school. But I do get to talk to the nurses as well and say, you know, pharmacy and nursing working together, and you don't have to be a medico, but it doesn't mean there's not a role for a medico. But I think everyone kind of just jumps to that by default, where there's so much more value out of that. So.
Yeah, hello all. I'm a social work student, and speaking of a career in health and mental well-being, I'm wondering, is there any room for social workers to play a role in this particular setting that we are discussing? Or maybe can you provide any ideas or suggestions for candidates with a social work background? Thank you.
I get to work with a number of different allied health professionals, and so that, and depending on whose definition you follow, allied health professionals can be up to 40 different professional groups. And one of those very important critical roles in healthcare is done by social workers, because essentially social workers are the last line of defense in terms of how to reduce risk for patients. Often social workers play an important role in a number of different areas, and that might be very simple as discharge planning. I was saying before, in a hospital setting, often social workers play an important role there. Social workers play a very important role in mental health, and I'm sure people from the north, in the Northern Adelaide Health Network area, in Salisbury, Elizabeth, and so on, would have heard about the Chloe Valentine case, where there was some really horrible child abuse issues there, and social workers are the front line at that. And in mental health, social workers have a huge role to play. So I think as a social work student, you should be really excited, because if you think about what are the opportunities you have in terms of making a change in a person's life, you could be working in a hospital setting, helping people to go home safely and well. You can be working in a mental health space where you can help with people with so many different problems. You can even work at the very young children's area in terms of looking at child protection and so on. So I think one of the biggest disciplines in allied health is social work, and it often happens to be one of the most diverse disciplines as well. And South Australian government has spent a lot of money recently, especially after the Chloe Valentine's case, in terms of funding social work to make sure that those kinds of abuses never happen again. So as a social work student, I think you should be quite excited about opportunities there are for you.
Yep. Actually, I think we're going to wind up now. So, so thank you everyone for coming along. Okay. Thanks.
Thank you.